I'm actually really excited. There's the data that's in here is part of it is from work that we've done over the past few years that was part of my PhD work, and also some new unpublished data that we have from a study that we did just last season, and was absolutely so excited about the results. So I'm excited to share them for the first time. Just basically what I'm going to go over today is talk about influenza, why it's important, why we need to be treating it, and then going over some of the challenges that we have in treating it, why it is so difficult to treat, including both challenges in diagnosis and our current state of antiviral treatment rates, and then kind of move into some potential solutions with particularly this new class of highly sensitive PCR-based rapid influenza testing, and looking at the cost utility and the clinical impact of those, and then actually just touch really briefly on influenza surveillance, because I think kind of understanding the prevalence and the pretest probability of influenza, it kind of plays in very much in that decision of to test and or to treat. So I think we all know that influenza causes significant morbidity and mortality each year. It's responsible for hundreds of thousands of hospitalizations and up to 50,000 deaths in the United States each year. And the CDC recommends antiviral treatment in specific populations where it's shown to have medical benefit. So it really kind of breaks down into three groups in terms of the recommendations. So I'll just go through those real quick. So the most severe group are patients who have severe complicated disease. So these are people admitted to the hospital that have evidence of lower respiratory tract disease. And in these people, the CDC recommends antiviral treatment as soon as possible. And in terms of the time frame, a lot of times customarily we think about that 48-hour time frame. There are a number of studies showing that the closer to symptom onset that treatment begins, the more effective it is. And then we've drawn about this 48-hour point where after that the effects are diminished. But in this admitted patient population, there are a number of different observational studies that suggest that extending that time frame out to 5 days is beneficial. So they really kind of have loosened the restrictions in this high-risk population who is showing signs of severe disease. The second group are people that have risk for having these severe complications but don't have them yet. So they're not admitted to the hospital. Maybe they don't have a severe pneumonia, but they're at risk for it. So these are the types of people you might expect. People that are extremes of age, very old, very young, living in a nursing home, have a chronic illness like diabetes or immunosuppression. Also in here is pregnant patients, and recently added with 2009 patients who are obese as well. And in this group, they do recommend treatment because it does prevent some of these outcomes that they're trying to avoid. But here they kind of tighten that time frame to that 48-hour time frame for treatment. And then the last group is the healthy people. So people that aren't at high risk, are otherwise healthy, don't have severe disease, and in these people it's not recommended to treat them. The CDC, is a little wishy-washy in its guidelines and leaves it up to the provider decision. If you want to treat, you can, but don't need to. But in general, it's not necessarily recommended. So one of the issues that comes up for me a lot when I'm talking about influenza is about the effectiveness of antivirals. And it's a really challenging topic because we don't have great studies on this. And given the current state of things, I don't think we're going to be getting any great studies. So when it comes to the kind of, the holy grail of a real randomized controlled trials, a lot of times what people cite to me is this Cochrane review that was published, I think it was like in 2013 was the first one, it was repeated in 2014. And basically, this looked at the trials that the drug companies did in order to get oseltamivir and zanamivir approved. Now, these trials from drug companies did not want to enroll people who were sick, people who were hospitalized, because that creates a lot of problems for them with the FDA. So they're mostly done in healthy people. In fact, most of the trials specifically excluded people with high-risk conditions or who were sick. So as you can tell by the title of the Cochrane Review, this is the neuraminidase inhibitors for preventing and treating influenza in healthy adults and children. So that's a population that's not recommended to receive treatment by the CDC. So this is one of the big problems, is that our trials supporting the use of, there are randomized controlled trials promoting the use of antiviral medications are done in a population that they're not necessarily recommended for. So the study showed that there was a reduction in, when you look at all the studies together, the Cochrane Review showed that there was a reduction in symptoms by about 1 day by using neuraminidase inhibitors. There was a reduction in pneumonia. There was actually a reduction in cardiac events, but it didn't show any impact on hospitalization. Out of almost 5,000 patients included in all of these trials, only 70 of them were admitted to the hospital. So this is clearly not a sick group. This is not that high-risk sick group that is having a much higher rate of hospitalization. In our studies looking at the high-risk people, our hospitalization rate was somewhere between 30 and 40%, not 1%. So these randomized controlled trials don't really impact the people that we're looking at treating. So to look at them really because of ethical issues, we really have to start looking at observational studies. So there have actually been two really nice systematic reviews of observational studies out there. And one specifically in admitted patients that showed reduced mortality, reduced ICU admission, and reduced pneumonia. And then another in high-risk patients with reduced mortality and reduced hospitalization. So again, they're observational studies. They're not randomized controlled trials, but pulling them together, we're seeing many, many studies showing a similar trend. Then when you kind of break down that high-risk category into different groups, there are different individual studies for some of those groups. So admitted patients is where I would argue we have our best evidence for. There are multiple observational studies showing reduction in mortality, reduction in length of stay. For diabetic patients, there's a study showing reduction in hospitalization. Pregnant patients, reduction in ICU admission and mortality. Nursing home residents, reduction in mortality, et cetera. So, one by one, they've clicked off a lot of these little high-risk groups. And that's a lot of times, that's where the committee from the CDC that came up with the recommendations, got that evidence from. So what really comes as a problem is it's been pretty well recognized that despite this building evidence and all these observational studies showing impact on mortality, hospitalization, length of stay, et cetera, we're not treating patients with influenza. And that really kind of brings up the core problem that I've sought to address. So the first thing was just to kind of quantify exactly what is that number. There's a lot of studies out there that look at the number of patients with influenza that were treated, but a lot of times they use, people that, where the clinician sent the test and was suspecting influenza, et cetera. And so they're missing a lot of people where maybe it wasn't in the clinician's differential diagnosis. So we did a study, a prospective observational study of 270 patients that came into our emergency department. And for all of them, we did influenza testing with gold standard PCR, and then just looked to see if they got treated or not. And so, and this is at the Johns Hopkins Emergency Department, 36% of our patients who had influenza and were in this high-risk category got antiviral treatment. So, especially when we look at a lot of the recent initiatives for sepsis and for antibiotics and pneumonia, et cetera, 36% is atrocious. So we are really not at all complying or going along with the CDC recommendations for this. And so, trying to dive into a little bit why that is, I think a lot of the challenge of this comes down to diagnosis. It's really hard to diagnose influenza. It's occurring during the winter. There are a lot of other circulating viruses. And how do we know it's influenza and decide who to treat? And so just looking at clinical testing, only 26% of these patients were tested for influenza. And that kind of gets into the challenges of testing and time. So as I mentioned before, treatment is most effective when given close to onset. And for some of these groups, recommended treatment is within 48 hours. So that needs to happen fast. But unfortunately, our good influenza tests are not fast. So there is the gold standard PCR, which typically takes 8 hours, maybe longer, not something you're going to be able to use in an emergency department. There's the DFA, which is kind of moderate sensitivity, moderate time. That's actually what we use at our shop. It takes about 4 hours or so to get that result back from the lab. And then there's rapid antigen testing, which comes back in 15 minutes. But these antigen-based tests are just horrible sensitivity, especially with H1N1 that we've seen circulating for the past several years. So their sensitivity is somewhere between 10 and 70%. So this all boils down to, at least in previous years, we haven't had a good test. And because that comes back in the time frame of a typical visit or ED visit. And so because of that, I think a lot of times clinicians have grown to distrust these rapid tests. Most of the rapid tests out there are these antigen-based ones that are not very sensitive. And the CDC issued this statement basically saying the DFA and the antigen tests are so unsensitive for this disease that even if they're negative, you should treat. And basically, if it's positive, great, then you confirm that diagnosis. But if it's negative, you're still back at the same point where you have to make this decision to treat or not treat based on your clinical suspicion. So So how good is your clinical suspicion? There have been so many studies looking at symptoms for flu and trying to use, a set of symptoms to try to diagnose flu, and they've pretty much all failed. So ILI, which is the CDC case definition, it's not meant to be necessarily used for diagnosis. It's a case definition, i.e. it's meant to be specific, but not necessarily sensitive. Only has a sensitivity of about 60%. Pulling other, groups of symptoms like cough and fever, this Monto study, which was a huge study, found the sensitivity of fever and cough was 64%. But when you take that down into a patient population that might not have a typical immune response, immunosuppressed, the elderly, i.e. these high-risk patients that you actually really care about diagnosing influenza in, when you get into those populations, that sensitivity drops. So there's this great study in people that were over the age of 60, and the sensitivity of fever and cough dropped to 30%. And so, I've always kind of believed in clinicians and that we are wonderful in our capabilities, and we consider more than just some prescribed set of symptoms, and we pull in the appearance of the patient, etc. And there was this study done by Stein in 2005, and he did look at healthy adults, and he found that his clinicians had a sensitivity of 29% for diagnosing flu. So you can't really rely on a set of symptoms, and you can't really rely on your clinical diagnosis. And as I already mentioned, the rapid antigen tests are horrible, and the good tests take too long, which puts us in a really kind of difficult spot. These are just a couple of different systematic reviews that basically said there's no real good set of symptoms. And so, as I mentioned, that Stein study was done in healthy people. So I wanted to see, what are we doing in the sick people? Again, these high-risk people that we want to diagnose flu and treat, the ones that are recommended to get treatment. So in that prospective study that we did before, not only did we do that PCR testing, but we also went to all the clinicians and we asked them, do you think this patient has flu, yes or no? And as their result, as I kind of mentioned before, we had 270 subjects. 46 of them ended up having influenza. And this only looked at patients who were in that high-risk category that's recommended to get antivirals. And what we found is our clinicians were 36% sensitive for diagnosing flu. We're awful. We're horrible. We're not any better than those rapid antigen-based tests. And just kind of this also drives home the point a little bit with influenza-like illness. In this population, influenza-like illness was only 31% sensitive. Now, it was reasonably specific. It was 88% specific. But if you're looking to diagnose and treat, you really got to rely on that sensitivity, and influenza-like illness just isn't cutting it. So, before I take everybody down too low, I know you're all very upset about the flu conundrum. So there has been a rise in the last, I would say, maybe 4 years of molecular-based testing. And I have a picture here of the expert flu. This is one test. There are other manufacturers, BioFire, Alere. There are other tests here. I don't mean to promote the expert flu, but this is one such test. And it happens to be one such test that you have at your institution. I just found out that you guys have had this starting last year. And so unlike the antigen-based tests that are attracted to a protein on the surface of the virus, this basically sequences the RNA within the virus. The advantage of that is the sensitivity is much greater. So this is a sensitivity of 95%. That's actually in that population I've been telling you about, those 270 patients we recruited and did PCR testing, we also did expert flu. So these are in ED patients that are high risk. We got a 35% sensitivity on them and a 99% specificity. And that's because this is PCR based, and so even when there are changes in these antigens, it will still keep with it. The other kind of advantages of this is it's single cartridge. You just pop it in the instrument. You don't have to wait for batch testing. It's really simple hands-on time. Actually, my research coordinators do it. The lab trained them, and they just do it. It doesn't just, pipette and in. And the time to result is, at this point, the test runs for 75 minutes. There's a new version coming out this year, which has influenza and RSV on it, and I think it runs for 52 minutes, I've heard from the company. That's longer than your 15 minutes of your rapid antigen test, but that's not your 8 hours for the routine PCR plus the requirements of batching, and and it's actually even much faster than our less sensitive DFA that we're using at Hopkins right now. So this provides a real opportunity to try to give clinicians a better idea of diagnosing flu, but then that really kind of brings into integrating this into our clinical testing. This isn't necessarily a cheap test. It's not as expensive as routine PCR. It's half the price of routine PCR, but it's maybe double the price of the rapid antigen test. So we wanted to look at the cost effectiveness of using this test. And then there are a bunch of other cost utility studies out there that look at influenza and look at testing versus treatment. Some of the downsides of the ones that have been done before, number one, they tend to look at the population as a whole, not the population coming in seeking care, which is really the population we care about. And second of all, they just use people with ILI. And like I've said, if you're just using ILI, you're going to be missing a huge population of flu tests. So you're going to want to be testing a broader population, just ILI. So as a result, when you see the study, the prevalences of flu are going to be lower than some of the other studies that are looking at ILI, but that's because we're using a broad, I believe, more clinically applicable population. So what we want, so we did this based on numbers that we found in the literature, where we looked at 4 different treatment strategies: treating everyone, treating no one, letting clinicians use their judgment, and doing a rapid test. And we just did these adults coming into the ED with a broad set of respiratory symptoms, and we only looked at the people who were at risk, i.e. who would receive treatment according to CDC guidelines. So we did this from a societal perspective, and we used the willingness to pay threshold of $50,000 per QALY. I think that's kind of a debatable, flexible guideline, but we did it just because it's standard. So this is our decision tree of how we did things. So we basically looked at those 4 branches, and either people had influenza or they didn't. They got treated or they didn't, and then they could break out whether they got hospitalized or discharged, and if they survived a hospital discharge, or if they died in the hospital. And if they were discharged, they could come back and have another hospitalization later on. They might have they might have complications, or they might just be just fine and have no complications. As with any cost-effective analysis, we had to make some assumptions, and within that, we assumed that all patients diagnosed with influenza were treated with an antiviral. That is a big assumption, but for this model, we made that. That the antiviral treatment was initiated within those 48 hours, and that the initial ED management was not affected by the diagnosis of influenza, in that if you had a patient coming in who was in respiratory distress, if they had influenza or not, you would take the same path of care for them. And then we assumed life expectancy was about 15 years based on other studies that we've seen, and that about 50% of the population is employed. This includes people that are chronically ill and the elderly, et cetera, so we gave it a little bit of a lower number. So this is what we found for our cost utility. Basically, treat none was dominated by everything else and was not ever a good cost-effective option for it. And then in looking at the cost utility ratios between looking at the incremental cost effectiveness ratios between provider judgment and the rapid diagnostic test, that was about $1,300 per QALY, far below our $50,000 threshold. And then for treat all was another $6,000. So if you're going, and this is kind of for the whole season, if you were going based on that $50,000 per QALY threshold, you would just do the treat all. Would be the most cost-effective option for this. I think there are some big problems with assuming that. There are a lot of other complicating factors that go into this, such as antiviral resistance, which we didn't factor in, et cetera. But that was what came out in the analysis as the most cost-effective. And then we kind of broke that down by influenza prevalence, because prevalence really is what is driving a lot of these numbers. And so what we can see here, again, using the $50,000 per QALY threshold, we found that for a prevalence of under 3%, in general, the most cost-effective option was just let the clinicians judge. When you got between 3% and 8%, doing the rapid test with the PCR-based test was most cost-effective. And then at an influenza prevalence above 8%, it was most cost-effective just to treat everyone. And again, there are a lot more implications and decisions that would go into a physician's decision whether or not to treat beyond just this, but this is an overall analysis of it. And just to kind of give you an idea about influenza prevalence in this population, the average throughout the entire season was 16%. So that kind of gives you, it varied between 0 and 40% was the range that we were looking at. So then we kind of looked to see if there were any sort of particular assumptions that might have really weakened this. I actually expect our assumptions about work and only 50% working to really impact it, but it didn't at all. The only 2 assumptions that we made that really impacted is the cost of the antiviral, and that if we went with a cheaper antiviral, and for here we use Antiviral, which is a little bit cheaper, that then the treat everyone just dominated everyone and was the most cost effective at any prevalence. And if we assume that there was no effect on mortality, then treating everybody went off and was not most cost effective. It would be most cost effective to use the rapid diagnostic test. So there's a lot of limitations in this study, and I will fully admit that. We're using these numbers from the literature, which are not always completely accurate. We're actually going to repeat this analysis with data from an upcoming study that we have. And as I mentioned before, we're not estimating antiviral resistance patterns or infection spread in this either. And all of this, though, it also assumes that the providers know what the prevalence of influenza is. How can you make these cost-effective decisions between, just using your judgment, using a rapid test, or just treating because the prevalence is high enough if you don't really understand the underlying prevalence? So that creates a little bit of a circular logic because you would have to test to know what the prevalence is. So just kind of this initial work, just to kind of sum up where we are so far, is that so the CDC recommends these antiviral treatments, but compliance with their guidelines are really poor. It's very difficult to diagnose influenza. We can't rely on antigen-based tests. Symptoms are not very sensitive, and clinician decision-making isn't very sensitive either. And we have these new tests that can be cost-effective at some prevalence thresholds, turn around in the time frame of an ED visit, and are highly sensitive. But then that really leads to the question is integrating these tests into our practice going to actually change what we do? If we give people this test and this information, is it going to actually, spur them to, start treating these patients, or how are we going to impact that? And so that leads into the study that we did last year. We affectionately call it the BARDA Study, which is a branch of the Assistant Secretary of Preparedness and Response of HHS that funded the study. And so it's actually a 2-year study. This is the first year. And basically what we did is we took all patients that came into the emergency department who met CDC guidelines for treatment. Again, we only cared about this high-risk group. And we had 4 sites spread throughout the country. 2 of the sites used this rapid test, and 2 of them didn't. The other 2 that didn't use it, they had an antigen-based test. That's what they clinically use, and we just let them do their usual care. All patients enrolled in the study got gold standard PCR testing in the background, so we had an idea of what everybody's actual flu status was. And then we had some key objectives. So one, we wanted to see the impact of this the impact of the PCR testing to see if that actually impacted antiviral treatment. We wanted to try to frame what population needs to be testing. So we started to come up with some clinical decision guideline, not to diagnose flu, but to decide who needed to be tested for flu. So our goal was to have a clinical decision guideline with a threshold sensitivity of greater than 90%. We didn't want to be missing lots of influenza patients for that, and we were going to take a hit on the specificity for that, but we wanted to be relatively inclusive because it's going to be used in a series with a test. And then also kind of based on this concept of prevalence really impacting your pretest probability and your decision about whether or not you should just treat or you should be testing, we experiment with this cloud-based surveillance system. So there's a bunch of different surveillance out there. The surveillance that we get from, from us, it's the Maryland, but I'm sure you have the same in Delaware, from the CDC, it comes about 2 weeks late. So if the issue that it comes out this week is from data a couple weeks ago. And working in the ED, we see all of these in real time as it's happening. So there've been a number of attempts to try to make that surveillance more real time. Most of them are based on symptoms, which, as we discussed, if there's a big RSV outbreak, who's to say that that might not be causing the symptomatic surveillance to rise? So we actually did this laboratory-based surveillance. Anytime we ran this rapid test, that test result automatically went up to the cloud and got aggregated with all the other test results and gave this, an estimate of the influenza prevalence at the institution in real time, and we fed that back to the clinicians. So these are our sites here, Baltimore, Kansas City, Phoenix, and Los Angeles. And the way the randomization worked, Baltimore and Los Angeles had the rapid test. So they had the expert flu, and Phoenix and Kansas City didn't. And overall, we enrolled a little over 2,000 subjects. And this is just kind of the demographics of the subjects we enrolled. And I think that this is pretty representative of what this high-risk population looks like in emergency departments. 36% of them got admitted, 11% had a pneumonia. And other than that, most commonly people had chronic pulmonary disease, COPD, asthma. There was a large population with diabetes and the metabolic disease, and cardiovascular disease. Again, this seems a pretty typical breakdown for what we see in our emergency departments. And these are how the influenza patterns went throughout the season. And it was really interesting to see the regional variation. So Truman, which is in Kansas City, Missouri, spiked first in December and then just dropped off, whereas most of the other sites had their big spike in January, with Hopkins kind of lagging on into February. And then at the end of the season, Maricopa in Arizona had this huge bee outbreak. They had like 17 cases of flu B in April. And when we talked to the site, they had no idea that they had that. They weren't on the rapid testing, so we weren't giving them the surveillance. And we talked to them later. We're like, yeah, how about that bee outbreak? And they're like, what bee outbreak? And so they really just didn't even know that they had that. we looked at the performance, because like I mentioned, all these sites had rapid tests. So we have a DFA, and the other sites have antigen-based tests. And these are the performance of the rapid antigen-based tests, which is really in line with, like I said, some of the data earlier. I would advise just to ignore all of you, which is the LA site, because they only had 15 people that got the rapid test. They were using the PCR-based test, and so I don't think they did much rapid. But all the other sites had well over 100 patients, and so they are pretty narrow with their confidence intervals. And again, it's 65% is great, but then you look at the REML expect in Truman, which only had 8% sensitivity. So yeah, I won't comment on that. But then the expert flu test had a sensitivity of 91% in this population. So I mean, it's just a clear advantage over these antigen-based tests. I kind of mentioned that we were working on that clinical decision guideline to make a decision who needs to be tested. And so for that, we took all of the patients and we collected symptoms from the patients. And what we came up with through our regression analysis is cough, subjective fever, headache, which is interesting because headache is not really in any other, it's not part of ILI, and it's not associated with flu in a lot of these symptom scales. But I think that as clinicians, I've certainly associated somewhat with flu just from my personal practice, and a triage temperature, basically a fever, a triage documented fever. So by using these three, we use a point scale because cough really had such a strong factor there. We came up with this clinical decision guideline where if you have 3 or more points, you get an influenza test. And by doing that, we had a sensitivity of an sample validation of about 92%. Specificity was pretty bad. It was 28%. But again, this is meant to be used in line. So this is trying to decide what population do we need to be testing? Because again, if you're testing just people with ILI, you're missing 70% of your patients with flu. So this was a fairly inclusive population of who needs to test. And now we get, and this was like so exciting when I saw these results, is looking at antiviral treatment and how using this rapid test impacted antiviral treatment. So for our sites that had the rapid test, 72% of the patients, and these are all high risk. These are only people that are high risk or recommended to get treatment by the CDC. 72% of them got antiviral treatment. Compared to our control sites that were, doing the regular thing, using the rapid antigen test, only 21% of the influenza patients got treated, which I think is just fascinating. And the other really kind of interesting, although I haven't fully come up with an explanation for it, is we also had slightly higher treatment in the influenza negative patients as well in the rapid treatment groups. 4% to 1%, is that really clinically significant? We could certainly debate that. But my theory on that is just because the rapid treatment sites had an understanding of what the prevalence of flu was, they might have been treating some of these influenza negative patients during the high prevalence periods, which the expert flu is 90% sensitive. It's not 100%. So I found that quite interesting as well. We tried to break it down to see what is impacting providers' decision to treat, what makes them treat these patients for influenza, and at all sites having a positive influenza test in the emergency department led to greater treatment. Kind of makes sense, common sense-wise, but also I think is telling about the challenges of diagnosis and how diagnosis really does impact our decision to treat. Another factor that really kind of came up was immunosuppression. So at our control sites, they were more likely to treat the immunosuppressed patients. So their influenza patients that get treated tend to be immunosuppressed. And also, if you look at the influenza negative test patients at the rapid testing sites, they also get treated. So it just kind of shows a protectiveness of, and probably appropriate protectiveness of the immunosuppressed patients in making sure that they're getting aggressive treatment. We also looked at the impact on antibiotic treatment. And there's some peds literature out on this. I haven't seen much in adults, but in kids, they've shown that by using a rapid flu test, they've decreased antibiotic use. So that's actually what I expected to see here, and I didn't see it. So patients who are influenza positive got antibiotics the same rate between the control sites and the testing sites. So it didn't really change our antibiotic treatments at all. Again, in trying to think about this, I perhaps wonder if my initial thoughts were wrong in that, in these pediatric studies, they're looking at kids in general tend to be fairly healthy. And if you have another source of their fever, maybe that ear isn't quite as red as you think. Whereas these are high-risk people. These are people with diabetes. These are people with, with lung disease. These are people, that are admitted that have a pneumonia. So, maybe in this higher risk population where there is, a reasonable risk of a bacterial co-infection that it's not as likely providers would treat. But I found that an interesting result, and I'm still working through the justification for that. And then the last part was this kind of laboratory surveillance that we gave back to our providers. So this is just a picture of the website. We gave all the clinicians logins to have them go to the website and look at the website, and only half of them did. They really didn't want to go and look at the website. They were busy doing other things and didn't really care about flu, which I totally get that as a busy clinician, yeah. So we did a survey, and we had 151 clinicians in our survey. We got 76% response rate, which I think is just, I found that outstanding. So we asked them before the flu season started, do you think that flu would be, information on influenza prevalence would be helpful? And the majority of them said yes. And we asked them what they thought would be helpful, and they said intermittent emails. They're not going to go look at a website or spend time on this. Just send me something in my inbox I can look at real quick and say, flu's 40% this week. All right. So that's what we did. So we sent them emails about every other week. You know, we sent them with big events, you know, the first flu case or when we saw a big spike. And so then we asked them, you know, did you find this useful? And so you can see here, the blue is the surveillance emails and the yellow is the website. People didn't really like the website so much. But, you know, 70% said it increased their general awareness. 30% said it impacted their decision to test for flu, and about 25% said it impacted their clinical diagnosis and whether or not they treated for flu. So, you know, at least a quarter to a half of our clinicians felt that, you know, the surveillance information impacted their clinical decision making and their decisions to test or to treat. And then we kind of asked them very directly, you know, how did this affect? And a lot of them said that they tested or treated more often. And, you know, less than half of them said that it didn't impact it. So I take this really to say that there's some significance in giving surveillance information to providers, because this influenza prevalence changes so dramatically throughout that influenza season. You saw in those graphs I showed you earlier, you know, week by week it can, you know, double in the prevalence. And giving the providers that information, just letting them know what's going on in their community, really gives them a much more accurate pretest probability for disease. So overall, you know, we have seen, and there continues to be poor compliance with CDC antiviral guidelines, but we developed this clinical decision guideline to help guide influenza testing and decide who needs to be treated with it. And if, you know, we found that integrating this molecular-based influenza testing, which you already have, I'm not sure how much it's used or how well people understand it, but really does impact antiviral treatment. And then also giving surveillance information impacts clinicians' practice and what they do. So what we're going to do this year, and I didn't outline it, so basically what we're doing is we're going to implement all this. So in RAD, when patients come in triage, they're going to get screened with the clinical decision guideline. If they have a score of 3 or more, they're going to get testing for flu, with the expert rapid PCR. And when that test result comes back, if it's positive, it's going to pop up to the clinicians and say, hey, your patient's flu positive. Do you want to treat them? And they can say no. They can say, you know, I don't think the patient's high risk, or, you know, it's been greater than 48 hours, or, you know, I don't want to. But it kind of prompts them a little bit and raises awareness on that to see if we can make sure that we're treating these people who are recommended to be treated. So that's all I have. This has been supported. I mentioned the BARDA study as well as the NIH. And please feel free to contact me. I love talking about all things flu related. And I welcome any questions. Yeah.
Thank you very much. What is your perspective on how this process may relate on a global basis to the Ebola virus?
So I think that there are definitely some components of this which could go towards Ebola. I think much more on the decision on the surveillance component of it. This idea of having this rapid surveillance that where the tests are automatically uploaded and you can identify that pinpoint. There are a number of global, because I think right now this is much more, like you said, a global problem. There are a number of different global surveillance systems similar to it. They're not as systematic, and they're not based on tests because, you know, obviously the tests for Ebola are not as rapid. But there are, and you know, there's health maps, and there's a number of different surveillance organizations out there that have global websites that pop up to show where things are spreading. And I think that's really changing how we think about disease and interact with disease. So I think from the surveillance perspective, this absolutely, you know, relates and could be of great benefit. You know, hopefully it won't have to be of benefit because the Ebola will be contained. But if not, I could see that playing a huge role. Yeah.
I was going to say, I mean, I think, I was struck by how low some of the treatment numbers were for hospitalized patients, and I think some of it is a holdover from 2009 pandemic, because, as we were kind of gearing up and preparing for it, there was a lot of concern about worry well showing up in the emergency departments and jamming up the system. So a lot of our education really went out to those that you don't need to treat, and they don't need to come into their, it's not an emergency, they don't need to come to the. And I think that was a big thrust, and there was concerns about Tamiflu shortages. And, I mean, we never said not to treat hospitalized patients, but somehow I think the message, it becomes very tricky to communicate exactly what.
Yeah. So I didn't include the data in here, but I also did this retrospective study, just looking at all the patients who were flu positive and RED, who got treated and who not, and just did some simple regressions, trying to see why people were getting treated. And it wasn't statistically significant, but the p-value was like 0.08. I mean, it was very close. But patients who are admitted to the hospital were almost less likely to be treated. And as well, for all the patients, I did a pneumonia severity index scale on them to see, how severe their disease was. There's some reasonable data stating that the PSI is approximate for influenza as well. And there was no association between, the more severely ill patients, the PSI level 4 and 5 patients getting treated. There was no association between the levels of PSI. So I think that there wasn't this recognition of, we need to be treating these more severe cases. And part of that, too, for us, I can tell you why our admitted patients weren't treated. For us, we have mandatory testing for patients that get admitted to the hospital. So I think that flu was something the physician didn't think about, didn't really consider. They've got infiltrated on the x-ray, it's a pneumonia. Here's your moxie, let's admit you. I have to send that flu test because the patient's getting admitted to the floor. You send that test when you click the admit button because you know you need to. Patient goes up to the floor, test comes back positive. Hopefully your hospital functions a little bit better than mine. Our patients often wait in the ED for a very long time for a bed. And so there's this huge opportunity, when time to treatment matters and a patient's in your ED for 12 hours, maybe that made a difference. And so that's part of the reason we're doing this testing now up at triage. So we get that test, we get that back in the time frame of the ED, and it's not, an afterthought of, the patient's admitted, I have to test for flu. And I think that's probably why our admitted patients these were clinically ordered flu tests weren't getting treated. Yeah.
So when you implement these changes, are you also going to recommend that patients empirically get started on antivirals?
So no, we're not. And I think that's a big point that you bring up. And that kind of flies in the face a little bit of the CDC recommendations. So the CDC recommendations clearly say if you suspect flu, treat, even until it's proven. But for using, that's the thing that I love about, this PCR-based testing. Again, not just the expert flu, but all of the thing, is that now we get that result back in 2 hours. 2 hours I can wait. When you're waiting for that PCR that's 8 hours plus maybe it's batch, so it only happens twice a day, then that's something that you really can't wait for. So I'm interpreting, and this is 100% my interpretation and no one else, but I'm interpreting that when, Timiaki of the CDC says, don't wait for that PCR, treat, after the rapid or a DFA, I'm interpreting that not to consider these new rapid PCRs. That was written back in the time before these were released. And so that's one of the real advantages. If you look back at the observational study that we did, where we tested the patients for flu, you'll see that of the people who were treated, of the people who got treated with flu, and I'm not sure if it's there, where is it? There were, I think, here we go. So if the patient who got antiviral treatment, 15 of the people that got antiviral treatment were influenza positive and 25 were influenza negative. So there were more negative patients treated than positives, and it's because we just don't know who to treat. And I think a lot of times that's led the clinicians to not treat because, they don't want to spread resistance if it's not going to do any benefit. That doesn't make sense. So I'm hopeful that, advising them to do this test and then treat if they're positive is going to help cut down on that and increase the incentive to treat. Yeah.
I guess I'm looking at it now from a perspective of a primary care physician. I'm assuming that I'm not going to be able to have this machine, so I'm going to be left with two choices: either make a decision or send them to the ER.
Yeah.
And I think one of the dangerous consequences of just kind of taking this information alone is that as a primary care physician, I'm going to be sending everybody to ED because you guys have to test. So now I'm going to overload your ED with all these people. So I guess I really like the idea real-time community prevalence of disease. And so I think as a primary care physician, if I can get access to, hey, you know what, in my local ED, the prevalence is now up to 17%.
Yeah.
And I'm having to be practicing med in ED, or I'm practicing in the community. Now I know the burden of disease or illness in the community with influenza is very high. I can treat empirically and probably do it safely rather than, or at least reasonably.
Yeah.
And not have to send everybody into the
I have struggled a lot with the concept of primary care doctors and how this, research impacts them. I've actually thought about you guys a lot, and there's two different aspects to it that make me struggle. So one is exactly that, is access to the test. And I will say, the expert system, the system itself is a little bit more expensive. It's a kind of 4-channel port. There are other ones out there that are cheaper. So one example is the BioFire. It's an individual cartridge, and it's literally a little box. It's not. It's just this little box. You do it on the thing and stick it. Yeah. So there are. Well, the platform. The platform is cheaper. Is expensive. So maybe there are some options, but let's say even there are. I'm not sure in the primary care clinic you're going to have your patients wait around for for an hour or maybe a little over an hour to get that test result back.
If we had that option,
yeah.
We've got a nice waiting room.
Yeah.
We would set up a process where we maybe had the nurses triage them with a symptom survey and then gave them the test, and then by the time they got to us, they'd be partially done with it. We could work that out.
We'll definitely look into that to see if we can get data out on a weekly basis. I'm Cynthia Flynn, the pathologist who's the section chief of the micro lab. So we do have this available at all 3 campuses. Let's have expanded capacity at all 3 campuses. So if all the outpatient docs who do have the ability to be close to the math lab, those docs can get specimens to us sooner and have information sooner as to be able to, especially if they are outpatients, and then have them, get their treatment. So, we do have this set up for all 3 campuses to be able to handle that. Obviously, we do need to prioritize our inpatient populations, our ED, our ICUs, etc. But we certainly are geared up to be able to handle the outpatient work. It'll be blasted to everybody next week, but I figured it was a good time to bring it out while we were discussing that.
So even if we could put relatively quick turnaround time prevalence statistics, or what's our, how many positives are we getting now, and what's the trajectory on the portal? We could even at least be much more aware of it and make better use of these kind of symptom surveys and then empiric treatment.
And what we've always recommended is that we don't have to test. Like once we've been established in the community, it's something we can do.
Yes, I think your point is absolutely right. I think 2009, and it really didn't carry over. And still a reluctance to treat empirically because.
Well, and some of these surveillance tools, they're relatively easy and cheap to do. And then it's just sending emails. How hard is it to just add emails? And I think that's a fantastic idea. And that kind of goes back a little bit to the cost effectiveness analysis, where treating all was fairly cost effective, especially at the high influenza, prevalence. It was the most cost effective option. And so, getting that understanding of prevalence is key.
Very much how the specimen is collected, food collection. But we also have people that are in on, that are willing to go out and train more in any part of the
Is there an option to give the patient a prescription and then call them if it's possible or chemical?
Yeah, I think that's an excellent option as well. Yeah, kind of the wait and see, and as soon as we get this test result, then go.
So there was an interesting kind of mid-season article that came out last year. I think we may have talked about it. That was in the Blue Journal about an observation they made about high severity illness patients who had not been vaccinated, and they saw this at a single center, so observational data, something obviously a caveat. But did you ever look at the impact of previous vaccination and then when they had the flu? Is there any effect there? So that would always be like for the clinician saying, boy, you have these symptoms, I tested you, and you haven't been vaccinated. That makes you a higher risk than someone who had been vaccinated.
So we looked at influenza vaccination when we looked at the factors that, kind of help decide whether or not a provider treated or not. Vaccination did not come out. They didn't really seem to consider vaccination in their decision to treat or not. And I think part of it maybe is, that's an extra question, and did I think to ask that? And another kind of aspect of that all is also a lot of these patients we're talking about immunosuppressed, the elderly, vaccination isn't as effective in them as well, and so they have higher rates of vaccine failure too. But there have been some really interesting, there's a nice cost-effective analysis that looked at, broke down the cost-effectiveness in people who were vaccinated and people who weren't vaccinated, and clearly they led to different results based on that because it really impacted the prevalence rates. The prevalence of influenza in those two populations is very different.
That raises another question, just my own self-interest. What would be a good rule of thumb in terms of failure rate for influenza vaccination? I've heard enough different numbers, and I'm curious what consensus on that is. In a healthy population versus an older population. What are we talking about?
I would say 10 to 20%, something like that. I would say in the elderly patients, I think I've seen numbers of failure somewhere between 10 and 20. I want to say for failure rate in the older patients.
All of them.
Yeah.
I'm like an ED, we know all about the vaccination.
Well, and it's yeah, and what the match is.
But it varies by season again based on that.
So I probably shouldn't be looking at that.
And we are promoting the high dose vaccine for the older population.
Well, thank you guys so much. I really appreciate it. And please, feel free to email me. I'm happy to send you our surveillance updates. We're just down the road. We're an hour away. I bet our prevalences are pretty similar. So thank you so much. I really appreciate it.